CMU, Jose Gomez-Marquez, who's a professor at MIT, who heads up the Innovations in International Health Lab, is that right? Which is part of the D Lab at MIT. And he was also named by MIT Technology Review one of the top 35 researchers under 35, and was named Humanitarian of the Year by MIT Technology Review, which is a particular honor. So I'm very excited for this talk. Jose?
Thanks a lot. As you all know, Adrian was also named one of the TR35. And that's where we met. I met his mom there too, so it was great. Thanks a lot for having me. Today has been a real treat. I've been to CMU once on the weekend when nobody really was here, so I really didn't get to see a whole lot. And I saw a lot of what I've always dreamed, like seen in the magazines that CMU has, and a few, and the general Pittsburgh area. So thanks a lot. I hope to come back. I'm going to talk a little bit about what we do with the MEDIK kit, and start it off with a little bit about what the challenges of global health technology are in the developing world. As a background, to give you, let me see if this thing, okay. As a background, MIT has about 2,500 to 3,000 students that participate in annual service projects. A good number of them are in international settings. We've expanded that in D-Lab to cover about 12 different classes that are at the intersection of development, international development, and technology. So you have the main core D-Lab classes, which are D-Lab development, design, and dissemination. And then recently we've expanded to sectoral classes that cover things such as wheelchair design, bicycle design, ICT, and I teach one called health. And the aim is basically to look at more particular topics than just simply appropriate technology and international development. In health, what we try to get our students to do is to design devices for an appropriate context in a very rapid manner. We know that they're not going to be able to learn everything about a medical device in a semester class, but what we do is we try to cram as much of familiar designs in the first half of a semester. Then we take them to Nicaragua. We show them real-world settings, real challenges, hospitals, clinics, and then they collect a lot of needs and look at improvisations on the ground, then come back to MIT and do some quick and dirty prototypes that can later lead to their own research or to research that other researchers in their lab will simply pick up. But sometimes the students will take them forward, and I'll give you a couple of examples of that. To kick it off, I don't know, how many of you are familiar with global health in general, and I generally kickstart this slide by global health. By its definition, is basically those international concerns that have to do with health that transcend borders, that are not just problems in the developing world or in the developed world, but because disease can travel through vectors or people or vehicles, in the end, it affects the entire world. And so we care about disease transfer, morbidity, access to healthcare, to systems. And most recently, it's been technology. And so at IIH, we focus specifically on what we can do for technology for global health. And to start, we look at the operating theater. If I go downtown to one of the hospitals, most likely what I'll see is something like on the upper left-hand corner of the screen. Really nice hospital beds, a lot of infrastructure. But if I go to the developing world, often what I'll see is clinics that are run down. They don't even look like clinics, but this is their public health system. A lot of times the access is done outside or semi-outside. What's interesting for us, I know as a design lesson, is that when you look at the other half of global health, which is not the public health systems, But what we see mostly on the news, that's what most of us get exposed to when we see global health, is a humanitarian aid examples. And when you look at the pictures on the right, it's very difficult to tell the difference between what's Katrina and what's Haiti, unless you start looking very specifically at small Qs. And what that tells us is that if we can treat international global health problems, those solutions can often come and do a trickle-up effect where we learn lessons so that when another Katrina hits, we know how to operate in that theater where, yes, there's a public health system, but a category 3 or 4 hurricane just blew it the hell out, and now you have to deal with that. And so you can learn from both systems, and we try to do that. Another thing that we focus on is our metrics such as life expectancy. I think most of us are familiar with looking at maps like this or just statistic like this that we end up looking at Africa. Africa, of course, always has either the darkest or the lightest color of whatever metric we're looking at. And this is useful, but a more useful metric sometimes is something we call the burden of disease in something called the disability adjusted life years. And economists like to parse out the details of what this means, but in general, for our purposes, basically, with this map, you're looking at age, right? How old do people live? So people in Norway live up to age 85. Great. But what the DALI tells us is not only your age, but your quality of life. So you live to 85, but you have a leg that is crippled. That means that maybe you weren't able to work for a good amount of your years. So if you add those two components of your productive life and your potential life, when you mash those up, it actually gives you your total output in terms of DALIs and how you can how to measure it better. For instance, you can have a person who could have lived healthily to age 40 or 50, for instance, just to make easy numbers, but because they didn't get a vaccine at the age of 5, an opportunistic disease basically cut off all their. They lived all those years, but maybe they lived again as somebody that was handicapped. And so you balance those two things, and it gives you a better indicator of what disease priorities should look at. And so the next slide kind of tells us that. So if you look, the top two are, are all these on the left are the usual suspects that we see when we look at mortality reasons. When you look at the one on the right, it changes slightly. They're still the same, but then some of them creep up that, and for instance, depression is there. Nobody actually dies from depression unless you can look at maybe suicide as an after effect. But it does in fact reduce your quality of life. So looking at DALIs allows us to prioritize. So right now we're working with the WHO on looking at an extended version of this DALI metric and taking a look at what certain diseases, the profile of how a certain disease is treated in conjunction with the potential technologies that you can work on for a disease. So to give you an example, you can work on a better ventilator for the developing world so that somebody in a NICU environment can have better chances of succeeding. But the fact that that technology is so complicated already, and by the time people are in a NICU, they don't have a lot of chances in the first place, you're investing a lot of money and a lot of resources for not a whole lot of marginal benefit. You can do the same type of engineering and do something as simple as a foot-powered nebulizer, which a lot of kids get when you have asthma, because the difference there is an extreme access gap between those that can afford a $70 nebulizer and those that can't, and end up having to wait in line at hospitals if they even get to the hospital at 2 a.m. And so those are the type of things that we're now interested in, and looking at what are those dynamics at work. I'm going to skip the next slide. But this basically just tries to illustrate the gap in access, the gap in expenditures. I always get shocked by the size of France. Sorry, Adrian. It looks like just this huge thing taking over Europe in terms of how much they spend in health. So, again, these are things that we already know. Some particulars about the gap in terms of the investing of funds for the rich and the poor. In 86 and between 86 and 2000, investments in R&D grew from 30 billion to 106 billion. But when you look at the number of drugs that were developed specifically for diseases in the developing world, that's I think less than 1%. 16 drugs, and if you throw in tropical diseases and tuberculosis, those were fortunate because those are diseases that we also care about when we send, for instance, soldiers to these areas. But it's not like people are investing a ton of money in things like Buruli ulcer or neglected diseases that we don't even hear about in America anymore. And the reason that's important, it's less of it's not so much of me trying to advocate more investment or trying to make it fair. What's important is it teaches us about a design approach. You cannot design something here, sell it here, and always expect it to work there, for one. More importantly, there are some things that here will never exist in the first place. We will never have Buruli ulcer in New Jersey. So where is that R&D going to come from? It's not going to come in the same way that we've seen technology transfers for other things. And that's what's happened to devices. With pharmaceuticals, we see a lot of advocacy going into dual market pricing mechanisms so people can have access to drugs. And with devices, what we see is a lot of folks who go to the developing world, they donate things, and they all take a picture in front of the truck or the church or the school or college, and then they leave. And then this is what happens. About 90% of all medical devices in the developing world are the result of hand-me-down donations. So they worked at a hospital here, and then somebody decided to donate them. What the stats tell us when we go to the developing world, to places like Nicaragua and Pakistan, is that many of them, within 6 months, are completely done. Something fused out, a part was not available, nobody trained the technician on how to use it, and so they end up basically in the back of the hospital at this great device graveyard, and they never come back to life. There's organizations that work on focusing on repairing them, but our approach at IIH is understanding that if you do that, you're basically trying to support a technology that was just simply not aimed to work in these environments. It was aimed to work in places like this, not in places where you have raindrops falling from the ceiling and uneven electricity sources. So when we teach our students how to design devices that will work in these places, we start with a notion of appropriate technology. But because we're dealing with medicine, it's not enough just to simply take an approach of saying, we'll just strip out the superfluous stuff and make something super simple or something that is super cheap. You can't imagine how many conversations I have with industrial designers who come to our lab, and we show them a device and say, okay, brainstorm, and they come back and they think that they can make it out of bamboo to make it cheaper. It's like, it's a medical device. It's not a water pump or a shelter. And so it takes a little bit of nuance. And when we first started teaching D-Lab Health about 3 years ago, we knew that was going to be an issue with our students, because when I ask you what you need for the developing world, oftentimes the immediate answer is it's got to be cheap. Yes, that's one aspect, but there's other parameters involved. So we came up with this, the Global Health Innovation Compass, and for lack of a better term. And what it allows us to do is take a look at design approaches using this continuum of tension, where you have the impact of a device and then the resource that it costs to develop that device. And then you can take almost any device and map it out along these lines. And so, for instance, if I wanted to treat, let's pick a disease, skin disease, okay? You can basically make a skin cancer clinic in every village in the developing world. You can build these systems up so that they mature and you have access to all these places. That can happen. There's a lot of people working to strengthen those systems, but it's going to take a long time. And even when that happens, you're dealing with maturing an entire system in some countries that don't have a continuous political environment, and so things just take forever. The other approach that a lot of people do on this end of the spectrum is let's invent a super pill. Let's make, you know, the vaccine for AIDS or the vaccine for skin cancer or something that will cost billions of dollars in NIH funding, that once it arrives, it'll be fantastic, but the reality is it's going to take a long time. And I don't advocate for stopping either of the approaches, but when you want to do something appropriate that has a more shorter timeline, you want to look at the other facets. And when we go down there, what ends up happening is that there's an immediate backlash against technology where what you see is a focus on, you know, how do we educate this person to wear long sleeve shirts, which is great because it's preventative medicine, but from our own position, we try to focus on what happens when the person already found something on their skin and now you have to treat them. That preventative message does nothing for them. We have to treat them. We don't have the system and we don't have the super pill, so now what? And so you look at distributed approaches. You look at how a nurse can go to that person's house and check on them. And you see, okay, how can we empower that nurse? And just, I use a phone just as an example, but you don't have to use a phone. You could give that nurse an iPhone. You can look up formularies, you can take pictures of it, you can make cool little apps that have onboard image processing, and you know, you guys can invent a lot of stuff for that iPhone so that it has like the ultimate skin cancer app, and it's got location-based systems, you can do onboard epidemiology, you can do a lot of stuff. But that iPhone is still about, you know, $600+ and plus the premium that you have to buy it in the developing world. What you can give that nurse, however, is one of these guys. $25, $30, whatever, much more accessible, but of course it's not as capable. And so what we try to find are catalytic technologies that will elevate the potential of that little cheap Nokia phone to something that approaches the iPhone. So in this case, for instance, just to get the message across, we could use SMSs. And if that thing has a camera, you could use MMSs to take pictures of those lesions, farm them out to a server that, you know, 100 of these Nokia phones all use, and have the server do the number crunching and the algorithms and all those cool database apps, and then farm it back to, and then SMS back to the nurse that says, okay, this was the weight, this was the lesion, this is what we think. And now access becomes a lot easier. The catalytic technology there is not the Nokia phone or the iPhone, it's the fact that we're using some sort of cool server technology to make that happen, and we're sharing it. And so by identifying those arrows, we slowly start to creep back up to this sweet spot, which is where we want to get, which is like high impact, low resource. You know, piggyback a diagnostic on top of that phone and now make that device a mobile diagnostic. You could add a lot of other things and you can take away other things, but the idea is that you want to be on a sweet spot. So identifying those technologies gives us a sense of where we want to be. Where we need to be in terms of like the specs are these attributes that we've looked at. You basically we divided them up in 3 different areas: essential, enhancing, and long-term. And I'm just going to throw through a couple that you guys might not be as familiar when we're designing stuff for here. In the developing world, obviously things have to be cheap, but you have to look at things such as Are you going to make it reusable, or are you going to make it disposable? How do you identify behaviors of things that were actually made disposable by people who want to make them reusable, like syringes? So you add auto-destruct systems. How do you do the inverse of things that were perfectly reusable, but because we're so litigious over here, we totally make them disposable? You want to make things smart. And what I mean smart, not so much computationally smart, but mechanically smart, or what's that department? Human interface? Yes, that's something that they would like, for instance. So there's a story in Nicaragua where the German Assistance Corporation, or GTC, donated a color ultrasound in the middle of nowhere to this clinic. $25,000 machine made by Siemens, fantastic. And World Soccer Cup time came around, and the technicians got a hold of the ultrasound, started playing with it, and said, I wonder if I could put a UHF antenna on this and watch the game. And they did. And there you go with a color ultrasound. 15 minutes later, you have a $25,000 doorstop. It would have been so easy to hack, but of course, that poor engineer in Germany who designed all the interfaces for the plugs would have never thought that some crazy person in Nicaragua is going to try to put an antenna on top of a color ultrasound. So smart would mean either adding a little voice box that says, please do not yank me because you're going to burn me up, or maybe make a socket for the UHF. I don't know. But these small things allow things to compensate for the lack of training that you're going to deploy your device in. And then the last two are basically look at how you can make things locally. And then what we try to do with our MEDIK, which was what I'm going to talk about today, is how can we make things so that it enhances the local innovative power of your users. So a couple of examples of things that work. This is Nicaragua, where we take our students in D-Lab Health over the summer. We take them to all these little clinics in the middle of the country. And one of our students noticed that a single hospital, a group of 16 hospitals were sharing a single glucometer. It turns out that diabetes in the developing world is a growing disease. As economies rise just a little bit, people can now start to afford more soda and more unrefined sugar, things that will probably lead to diabetic conditions because of diet, because of genetics. And while diabetes is now a disease that we are able to cope with and manage in the States, a lot of the tools that we need to manage diabetes in the developing world are really not available. Glucometry is one of them. And as in the example of these hospitals that were sharing a single glucometer, people just don't have a way to measure their glucose. Oftentimes what ends up happening, you see, is those glucometers get donated, again, from goodwill groups, and they have a little sample pack of the different strips. The glucometers here, if you go to CVS, are about $10 to $15 to $20. But when you try to buy the strips are about 60 to 80. They're very expensive because that's the business model. So you're in Nicaragua, you get a free glucometer, and now you need to buy $80 strips. So you don't. So my students came back and they were all scandalized. And what they did is a very simple glucometer that took a very old technology of colorimetric tests and then mashed it up with a very sensitive optical sensor that could tell the colorimetric change on a lateral flow strip. And they started by basically making a red, yellow, and green interface, and then they started adding resolution to that. It's not as effective as the one you could buy at CVS. Here's a little strip that you add. But it's better than the standard of care they have right now, which is basically if you're a pediatric patient, your mother takes a teaspoon of urine and tastes it, and if it's sweet, that means your blood sugar is high. So we can do a little bit better than that by starting. I like this project because that's Dipali, one of my students, and the program is geared so that you don't have to be an engineer to start designing things. She was a biology student. And I got a call from her dad saying, I never thought my daughter would ask me for help on how to make a circuit. And then I ran into my department head and found out that the dad was a former CTO of National Instruments. And a friend of my department head. So these are some other devices we've been working on. This is Aerovax, something I've been involved in. And the idea here is take existing measles vaccine, aerosolize it, so that you can deliver the vaccine via inhalation instead of shots. Shots are great. I mean, they're the foot soldiers of vaccination campaigns. But because people are reusing needles often, about a third of all injections in the developing world are deemed unsafe. And according to somebody at UNICEF who manages vaccination campaigns, about 2/3 of all syringes have been in the arm of another person. They may have been sterilized, but they've been in the arm of another person. It leads to about 250,000 cases of HIV a year and about 2 million cases of Hep B. So syringes are bad, again, because these systems sometimes are not ready for it. So if you can avoid that with aerosol, it could be an improvement. So this machine is designed to deliver about 800 doses of vaccine and go without refrigeration for about 7 days. Here are some of my students testing some of the rigs out and looking at the aerosol. Another project that we're working on is instrument sterilization. Sterilization is a huge problem in the developing world. Again, they get these legacy autoclaves. They suck an enormous amount of power, and they often break. So the idea here is, how do we clean instruments better in a more sustainable way? So we're connecting a parabola to a boiler that's basically feeding pressurized steam into a pressure chamber, which is essentially what an autoclave does. And here are some early pictures and our students working on it. XLTB is a project that we've been working on for a while now. And the idea here is adherence. Adherence, lack of compliance or adherence to your medicine. You don't take your medicine. It cost the US healthcare system about $100 billion last year in follow-on care. With tuberculosis, it's also a problem. You have patients that need to take their pills for about 8 months, 6 to 8 months, depending on where you are in the world. And you need to take your antibiotics almost every day. So what ends up happening is that the patient comes in, they find out they have TB, they're feeling really bad, they take their pills. After about 1 month and a half, they feel better. The antibiotics are taking hold. But they still have side effects of the pills. So they drop the treatment. And after dropping the treatment, what ends up happening is that the bug often creates resistance against that first-line medication. And now your cost of treatment shoots from about $120 to $900+ because you have to use more advanced medications. And in some countries where the annual percentage of healthcare invested per patient is going to be less than $100, that's a death sentence. So they came to us and they said, we need a system for people to take their pills. And my first reaction was, that's really boring. Like, as a little pill counter in CVS, like, how bad can it get? And when we start to look at the problem, we could see that it involved a little bit of behavior change, verification, and we assembled a team, and what we came up with is XLTB. And the idea is that you get a reminder to take your pill, and then you take a test. Because we looked at a lot of reminder systems, and there was no way that you could effectively know whether that reminder caused the patient to take the pill. And so what we did is we test the patients for their own good. And we give them these diagnostic strips, and the strip actually, instead of saying yes, no, they actually emit a code. So over here, the code could be 2-3 or 3-2. They send it back over SMS, and then we have some behavioral economists on the team that rigged up this incentive scheme to actually reward them with cell phone minutes. And so that creates a little carrot every day for the patient to continually take their pill instead of waiting for 8 months. Yes, 8 months you will live, but human behavior just simply doesn't work that way. And so XLTB is now being rolled out in Pakistan and Nicaragua. We have a 1,600 patient trial over there. And it's one of these technologies that is now trickling back up to the States. We have a number of companies asking us, can it be used for other diseases? We have people with heart trouble and diabetics who don't take their medication and it leads to, like, emergency visits, hospitalizations. What can we do for them? So now we're finding other metabolites and tracers that can work for those diseases. But the design lesson here is that had I started by figuring out how to make a compliance system for my grandmother in Florida, I would have probably come up with a really cool iPhone app and some sort of expensive sensor system, instead of coming up with something that was so constrained that had to be less than 1/10 of a penny per strip and deployable regardless of the hardware. These are some more crazy projects, but after visiting here, I don't think this is going to impress you. We have distances between clinics. You have a mountain, you need to transfer biopsy samples or medicine or diagnostics. And so what we're working on is we're starting to look at what would happen if we load them onto a plane. And we're not there yet. We're here. But what we're trying to do is look at open source avionics and stuff to take existing gliders and outfit them, because that's going to be about a $1,200 investment as opposed to a $20,000, $30,000 truck plus driver plus gas. And when we look at projects like this, this is what I always run into when I come back to the lab. I don't know if you can read. But I generally try not to touch things when my students get it to work, because I generally break it. Let me sort of skip through this. And so going now back to the MEDIK project, when we were working in Nicaragua, one of the things that we ran into was that our XLTB strip left MIT working half the time. The specificity was okay. We thought we were going to deploy incentive schemes based on microcredit and had this very complicated, really cool voucher system associated with it. Because when you look up international development, you get to the business part of a proposal, microfinance seems to fit the bill. When we got to Nicaragua, the scientists down there worked with our group to fix the test, and they said, don't use microcredit, that's going to be a bureaucratic nightmare, just use cell phone minutes. And both of those contributions to the project really launched the project to where it is today. And that sort of started to tell us, frankly, these folks are bright. They know their problems better than we do. They have a lot of the education, and if they don't, they have a lot of the work experience. They just need better tools. So we launched something called the MEDIK kit, which stands for Medical Education, Design, and Invention kits, to basically give a doctor and a nurse who's already MacGyvering their way out of a solution in a hospital ward, giving more formal tools and introduce them to more accessible technologies so that they can experiment, they can design, and then instead they can call us. If you notice that Skype was one of them calling me right now. So they can call us and say, you know what, I invented this week. What do you think? Can I send it over to MIT and maybe you can check it out a little bit more? Instead of the usual thing that we hear about when we talk about developing world linkages, where we come back with like a laundry list of shopping needs, and now we have to work on them. So they kind of look like this. They're basically labs in a box, and they have a lot of different components that people can put together. This one in particular is a kit to make diagnostics. So what we did is we embedded puzzle pieces with reagents so that nurses can basically mix and match different lateral flow assays based on the different combinations that they want. And they're color-coded so that they can share the different combinations with other nurses that have the same kit, and they can recreate those tests. And so these are some of our students working on the drug delivery kit, which is basically a kit of parts that allows people to put syringes together, put dual chamber syringes together, put foot-powered nebulizers like the one I brought over. And oftentimes this exercise, which is basically just to get them started in design, we give them zip ties and we give them syringes and we say, make an auto-disable syringe. And they came up with a much more clever mechanisms than my fourth-year mechanical engineering MIT students. And so the talent is there. We just need to give it some tools. These are some of our nurses, again, making 2 patient nebulizers using one of the MEDIK kits. So here's the nebulizer, and here are the two face masks. We figured out a way how to make microfluidics on the cheap by using something called xerography, which is basically using an XY stage or a cutter plotter with a knife attached to it. And then you cut the channels on double-sided tape and you sandwich them to make your microfluidic walls. And these are some examples of it. These are more examples, some of our MIT students trying to practice in some of our channels. These are, again, our puzzle piece diagnostics. That was the main intention. And the next part of the kit was really, how do you create a language of design? How, I think, I don't know if there are any MEs here, or if you've seen a mechatronics or a mechanical engineering book. Oftentimes you open and you go to a picture of an engine and all the cams are red and all the pistons are yellow and the main engine block is color-coded blue. In real life, it doesn't really look like that, but those illustrations are there for you to know exactly what you're looking at. So we recognize that when they open a lot of these devices, it looks very scary. This is an Advair inhaler. And what we went is we started to color code the different mechanisms so that they could make a little bit more sense of it. So in this case, for instance, the blue part is control. The green part is drivetrain or power. The yellow part, you don't really see it here, but you'll see it in another slide, is where it interfaces the patients. So when they see another inhaler in that kit or another piece of equipment in that kit that has the exact same color scheme, they may not know what it does, but at least they know an aspect of what it does. And it reduces the mystical quality of designing these devices. It tries to demystify them. So these are some lateral flow assays using the diagnostic kit with a sensor attached to it that our students were making. These are an evolution of those blocks. Again, using concepts such as color coding and creating languages of design so that they can put 3 different reagents together on a lateral flow test bed. They take a picture of it, somebody else with the exact same of blocks, or maybe an array of 36 possible blocks, can just simply put them together like Lego pieces, instead of sending out a formula in a bill of materials of reagents and a pipette. Because that adds experimental error, that adds where am I going to get those reagents, and all these other things that is their reality, basically. These are some of the other devices color-coded to try to, again, enable this concept of a language of design. And I bought one of them over here. I need a little bit of water. I'm going to take a break, not for me, but for a demo. So I may be a volunteer, I don't know. Okay. And so this is basically one of the excerpts one of the technologies that are available with our MEDIK kit. And does everybody know what a nebulizer is? So basically, it's a small device used for aerosolization. And what it does is it aerosolizes stuff in here. Generally, when you buy them online, you buy an entire system, and it's about between $40 to $70. There's some as pricey as $200. And in Latin America specifically, asthma is very prevalent, and so these things get used a lot. But it's $70, so they only exist in the hospital. We took the expensive part out and figured out that you could use simple devices. So if you want to hook this up, look, you hook that to that bottom part, and I'll connect this to the bike pump. And it works pretty much the same as if you were using an electrically powered compressor. And so I'm going to take the water they gave me, and we'll pretend this is like asthma medicine or something. And if you hold it, I would use my foot, but I want to show you. Hopefully it's not a demo fail. And so basically that can save a kid's life if you're in the middle of nowhere and you don't have access to a clinic or electricity and they're having an asthma attack without access to an inhaler. And this is about $2, and I can buy these in Nicaragua for about $4. In fact, they're cheaper in Nicaragua, so I just buy a bunch and bring them to Cambridge to teach. So these are these simple devices that, you know, I could design aspects of it, but sometimes it's just simply a matter of showing people how to put them together. You can take it off. And, you know, could I over-engineer it? Sure, I could make a lot of things to make it, just...
I don't want to waste them.
No. You know, but we often look at these things. There's no way I'm going to get a master's thesis doing that. You know, I'd have to do some serious simulation stuff on that flow to make it worthwhile. But I have to look at, you know, when you're doing these things, are you going to go for the impact factor of a journal or the impact factor of a patient? And sometimes that's a decision you have to make. Sorry, this is, let's see. These were manufacturing facilities that we started for XLTB. XLTB uses basically embedded reagents on chromatography paper. This is not chromatography paper. This is not Nicaragua either. This is actually one of the labs at MIT, and one day we ran out of chromatography paper and space, so we ended up using coffee filters from Melita is a good brand, and embedded our reagent cocktail in the coffee mixers, slung them up on a line, and they worked. Because we had a group of people from Pakistan coming in like in 4 days to pick up 1,000 strips. And little experiences like these just, again, confirm to us, you know, if we could do it in the middle of the bike shop that we had to like extend our wet lab into to produce these things, we can do a lot of these devices in the middle of nowhere. Maybe not, you know, invasive devices, but certainly a lot of the point of care and mechanically driven devices. And basically, that's it. So if anybody has any questions, I think our time is up. But in general, that's what MEDIK tries to do. It tries to empower doctors and patients in an indirect fashion in the developing world with tools that would otherwise be just in places like ours. And you know, hopefully we can learn from them and launch new projects. So, thanks. Any questions?
Well, so as I was listening to your talk, I felt like you seem to be operating in an environment in which like rich, well-meaning people are throwing money at idiotic things. And then you're sort of in the middle of it, building useful things for no money at all, basically. And so I guess my question is, what if you could be in charge of the Gates Foundation and all these huge foundations who are building hospitals and stuff with the road, what would you tell them to do with all their resources?
Well, first, I think, you know, I would tell them to have a technologist on board, you know, at the Ministry of Health, because sometimes it's all they have right now are basically an acquisitions officer who looks at the same catalog that the acquisitions officer at, you know, the hospital down the street here has, and that's not the type of catalog they want to be looking at. That's like somebody going on a camping trip and not even considering REI and just going to Saks Fifth Avenue. And so that's one. And I think there's still a lot of this, it's sort of a neo-colonialist approach with design that says only we can design these things. if they look closer, they'll find that there's a lot of good people out there, and it's just a matter of how to get them the better tools so that they can solve their own problems. Problems that, I think a lot of these institutions sort of retract from that because they say, oh, but quality, it'll never be as high quality as when you design it over here at CMU. And what they don't publish, or what they don't really admit, is sure, you can take an FDA-based device that went through all sorts of testing for this market, take an incubator, for instance, and now you're deploying it in a developing world market, and it is FDA approval. It gets there perhaps new 5 years later. It breaks down, and now the refrigerator repairman has to fix it. And now I guarantee you that FDA device is not FDA approved. So that sort of logic, I think, needs to come into play.
How do you think you will encourage people to get into this market and then motivate them to build such devices? Because if you think about scalability, say in India we had tsunami, and when a number of people got injured, a number of people trying to help people who got injured were very less. They were like, during the initial part of that, when natural disaster happens, you have very less equipment. So how will you encourage other people, technology or academia, to come and build such devices so that the production will be higher than that is currently?
I mean, one is to recognize that these environments have a market. I think we shouldn't be pursuing these things just because we're nice guys or girls. They should be pursued because there's a market. Sure, there's a need and you want to help. But if you notice, we're not sitting around having conferences about how to donate cell phones to Africa anymore. Like, they have conferences about how to take advantage of business of the cell phone in Africa. Where is that moment for medical devices in the developing world? And two, I think you need to pursue a lot of these things because even though some of these solutions, I joke at this because everybody likes it and it's just so simple. But there's other challenges that are quite rigorous. Incubators, we have to keep a baby alive in the middle of nowhere without electricity or unreliable electricity, without any trained personnel, and they're premature and they're highly at risk. And then we get to keep an astronaut alive in the space station. One problem gets $1 billion thrown at it as a price tag, not to mention the R&D. The other problem gets less than $1,000 available to it and much less R&D. So which is going to be the harder problem to tackle? And so you should look at it as engineers and designers in that way. Not just, oh, let's just do it because, the poor baby. The reality is these are some interesting problems, I think.
So how does this problem space intersect with academia in terms of incentives for publication and other sort of traditional incentive structures for students and faculty to participate?
I think that's one of the, traditionally it's been, I think it started as the service learning engineering component of a lot of universities, but that only takes you so far. I've heard people that are actually well respected in the space call it a tenure killer, and that's a really we haven't solved that incentive structure for these devices. We also haven't solved the funding structure for these things. So it's tough out there. You cannot get a lot of NIH funding for this type of work. And everybody, when I tell people what I do for a living, it's the second thing they say is like, have you heard of the Gates Foundation? And I kind of pretend I was like, software guy, really? And everybody assumes that they're going to bankroll everything, and they don't. And especially when things are at the seedling of an idea. And so it's still challenging. However, you can take advantage of the fact that you can publish something that's a concept of a technology, but few people get to make it work in a developing world setting. So either you can pursue a publication on just the technical merits of it, because you figured out how to make a baby incubator out of phase change material or something like that, or you can maybe pursue something based on the fact that you were able to trial it and get epidemiological data in this part of the country that had never seen an incubator, for instance. So there's, not all is lost, but it's still a very maturing ground. Yeah.
Still try to get some feedback from the users from the developing countries and use their comments as part of this design.
Feedback from the, well, that's why we specifically came up with a MEDIK kit, to enable them to give us more feedback, but not just through verbal feedback, but through actual construction building blocks, so that they can say, this is how I would do it here. Yeah, I mean, that's critical. So, yeah.
You mentioned that some students continue the projects beyond, the initial stage, and I was wondering what kind of personal impact it's had on some of the students that you've worked with and on you, for them to kind of create something that they really see the impact of.
I think they do well, because it definitely shows them that beyond the engineering lesson, there's a responsibility of looking at your community partner and knowing that you have to deliver somehow, or at least show them that you're trying to deliver. I think that's been the biggest lesson, especially when you're doing a water pump or another type of appropriate technology that's easier. You can be done in a month. A medical device can take years, if of commitment, and so that makes it a little bit more challenging. But we've seen that in some of our students, and we've also seen them mature to the point where they can admit and say, what, I'm going to graduate school. I'm not going to be able to continue this because my master's thesis involves something entirely different. I'll hand it off to somebody who will take it on almost in a more professional staff role. Yes?
Have there been any follow-ups to, like, for instance, you mentioned the TB project and the diabetes project? Has there been any follow-up to see whether or not, when you implemented whatever technology it was there a difference in patient outcomes or anything like that?
That's what we're testing in Pakistan right now.
Okay.
So there's a randomized trial in Pakistan with actually it went up to like 3,000 patients, 1,600 on each end, control and random. And that's really going to tell us, how well we moved the needle, of course.